Welcome to the Deep Dive. As dental professionals, we see it all the time. Patients, sometimes surprisingly young, come in wanting a brighter smile. Or maybe you're the one noticing discoloration that could be impacting a child or adolescent, and the question immediately pops up in your mind.
Yeah, absolutely. Is this okay for them?
Is tooth bleaching actually safe and effective for our younger patients? It's a question many of us wrestle with. There's a real clinical uncertainty here. How much?
Well, it seems significant.
Yeah, this source material points to a survey revealing that 68% of dental professionals don't even offer bleaching treatments to children.
68%. Wow.
And a big chunk of those 55% specifically cite concerns about side effects in this younger population as their main reason.
Right. And that makes sense, doesn't it?
That statistic alone highlights the gap in our confidence and the need for clearer guidance.
Precisely. That uncertainty largely stems from the fact that the majority of the robust clinical evidence we've historically relied upon has focused on adults. You know, the unique considerations of developing dentition in children and adolescents often leave clinicians hesitant.
Exactly. And that's why we're doing a deep dive into this specific piece of research today. It's a scoping review specifically designed to map out everything that is known about this topic.
Okay.
The title is, Are Tooth Bleaching Procedures Safe for Children and Adolescents? A scoping review of color change, side effects, and impact on patient satisfaction. The authors are Cynthia Mayara Medeiros Teixeira Lopes, Francisca Jennifer Duarte de Oliveira, and colleagues, published in the Journal of Dentistry with a publication date of 2025.
This kind of review is incredibly valuable. Instead of just looking at one or two studies, a scoping review takes a wide-angle lens to the entire body of existing literature.
Yeah.
It doesn't necessarily provide a definitive answer or quality assessment like a systematic review might, but it shows us the landscape, what research exists, what's been studied, and importantly, where the big gaps still are.
Right. And our mission today is to unpack this review, synthesizing its findings specifically for you, the clinician in practice. We're going to pull out the key findings regarding color change, side effects, and patient satisfaction in this specific population.
Which they defined as?
Which the review defines as children and adolescents aged 3 to 18.
3. Okay, so a really wide age range.
Exactly. We want to give you a clear, evidence-based picture drawn from the existing research to help inform your clinical decisions moving forward.
So you can move beyond relying solely on individual case experiences or, generalized adult protocols, and instead base your discussions and treatment considerations on a synthesis of what the available literature actually reports about this age group.
Okay, let's unpack this. So before we even get to the findings of the review, let's set the stage a bit. Why is tooth bleaching even a topic we need to consider for children and adolescents in the first place?
Yeah, good question.
We know in adult dentistry, it's one of the most popular minimally invasive procedures for aesthetics and boosting self-esteem.
And those same motivations and potential benefits apply just as strongly, if not more so, during formative years. This review highlights several specific clinical reasons younger patients might present with discolorations severe enough to warrant considering bleaching.
What were the main drivers they identified across the included studies? What sort of things came up?
Well, the most common reason cited in the literature was generalized tooth discoloration, often described simply as a shade darker than A2 on the Vita scale. This was the primary indication in 20 of the 40 included articles.
Okay, so just overall yellowing or darkness.
Yeah. Beyond that, post-orthodontic discoloration is a frequent clinical observation, right? And it showed up in the literature base as a reason for bleaching in this age group.
Right, after the braces come on.
Exactly. Tetracycline-related staining, although perhaps less common now, was also noted and is notoriously challenging to treat.
Oh, definitely. And I know the source specifically calls out trauma as a frequent cause of darkening in young teeth. That's something we definitely see clinically.
Yes, absolutely. And the review findings back that up. Out of those 20 articles citing general discoloration, 8 specifically noted that the darkening was a consequence of a previous traumatic injury.
Almost half of those cases.
Yeah, it's a significant group of patients who could potentially benefit. The review also found studies addressing less frequent but still important reasons for bleaching, such as hypomineralization, hypoplasia, molar incisor hypomineralization, or MIH.
MIH, yeah.
Amelogenesis imperfecta, and even some cases of idiopathic brown staining where the cause wasn't immediately clear.
These aren't just minor aesthetic imperfections, are they? The psychosocial impact seems like a really key element here, especially in kids and teens.
This is where it gets really interesting, and it's a crucial point for clinicians to consider. The review emphasizes the profound significance that changes in tooth color can have, particularly during the critical developmental stages of childhood and adolescence.
Yeah, image is so important, though.
Totally. Discoloration can lead to genuine dissatisfaction with appearance, which can, in turn, contribute to low self-esteem, make a child or teen a target for bullying, and even be associated with broader mental health challenges. Frame this correctly for your patients and their parents. Bleaching in these specific clinical scenarios isn't just a cosmetic luxury.
Right, it's more than vanity.
As presented in the source, it's a potential treatment option that can play a vital role in mitigating these serious psychosocial issues and significantly enhancing a young patient's overall well-being and quality of life. Some of the studies included in the review actually reported on this positive impact.
And that, I think, is the core problem this review is designed to help us navigate. We have these compelling clinical needs and potential psychosocial benefits for younger patients, but the lack of specific synthesized evidence for this age group creates that uncertainty we started with, right?
Exactly. That evidence gap is precisely what drives that statistic of dentists being hesitant to offer treatment. Adult protocols can't always be directly extrapolated to developing dentition. This review's aim, therefore, is to provide that much-needed comprehensive synthesis of the existing literature specifically for children and adolescents to help bridge that gap in clinical confidence.
Okay. So how did the authors go about mapping this landscape? Let's talk about their methodology, how they conducted this deep dive into the literature. What kind of study is this?
As they state, this was designed as a scoping review. The fundamental purpose of its scoping review, as per the source, is to systematically map the existing literature on a broad topic to understand its scope, nature, and volume.
So, like taking stock of what's out there.
Exactly. They followed established, rigorous guidelines for conducting and reporting scoping reviews, specifically the preferred reporting items for systematic reviews and meta-analyses extension for scoping reviews, known as PRISMA-SCIR.
Okay, PRISMA-SCIR.
And the guidelines set out by the Joanna Briggs Institute, or JBI.
JBI, got it.
They also registered their review protocol in the Open Science Framework, which adds a layer of transparency to their process, showing their plan up front.
Okay, so they systematically mapped the existing evidence. How did they define the specific area they were mapping? What was their actual research question?
They structured their research question using the standard PCC framework, which stands for Population, Concept, and Context.
PCC, okay.
Their target population, P, was clearly defined as children and adolescents undergoing tooth bleaching. The concept, C, was deliberately broad to capture everything related to the topic.
Like all the different angles.
Yeah, including the specific techniques used, the types of bleaching agents, the protocols followed, the duration of follow-up, how efficacy or effectiveness was measured, safety aspects, patient satisfaction, acceptance of the treatment, and reported side effects. Basically anything relevant.
Okay. And the context?
And the context, C, was not restricted to any specific setting or type of clinical scenario, ensuring they captured a wide range of studies.
So not just in office or just one country. Broad scope.
Yeah.
Okay. What about their criteria for deciding which studies made it into the review and which didn't? What were their inclusion and exclusion rules?
They included any human studies that evaluated tooth bleaching treatment specifically in children and adolescents.
Right.
A key aspect here is that they set a maximum age of 18.
18.
But they established no minimum age.
No minimum. Wow.
Yeah, this is important because it meant studies involving very young children, including a case report of a 3-year-old, were potentially eligible for inclusion.
Okay. And what do they exclude?
They excluded studies that included patients over 18, as well as letters to the editor and study protocols that didn't report actual results.
Makes sense. Just the finished research.
Right. To ensure a comprehensive search, they didn't apply any restrictions based on language or the year of publication, seeking to capture all relevant literature globally and historically.
Okay, so a really wide net. Where did they actually look for these studies? Which databases and sources did they search?
He performed a broad search across several major electronic databases to capture both medical and dental literature. These included PubMed, Web of Science, Scopus, Embase, and ILACS.
The usual suspects.
Pretty much. And to find studies that might not be formally published in peer-reviewed journals, they also searched relevant gray literature sources, specifically clinicaltrials.gov for registered trials and OpenGray, where they screened the first 100 records.
Okay, digging deeper than just journals.
Yeah, the search was conducted relatively recently, between April and May of 2024, and was last updated in March 2025, meaning they captured the very latest available research.
Good. So it's up to date. That sounds like a thorough process to gather everything out there. How did they decide which studies from that massive search actually met their inclusion criteria? How did they sift through it all?
They used a standard two-phase screening process to minimize bias. Initially, 2 independent reviewers screened all the titles and abstracts retrieved from their search.
2 people looking independently.
Exactly. These reviewers had been previously calibrated to ensure consistency in their application of the criteria. To check their agreement on which studies seemed potentially relevant, they used the kappa test.
Ah, the kappa statistic.
And the result was a K-value of 0.8175, which indicates a substantial agreement between the reviewers. That's a good sign of reliability in their initial selection.
Okay, so they mostly agreed on the first pass. What next?
After this abstract screening, the same 2 independent reviewers performed a full-text assessment of all the articles that passed the first stage, reading the whole paper. If those 2 reviewers disagreed on whether a particular study should be included or excluded after reading the full text, a 3rd reviewer was brought in to resolve the conflict and make the final decision.
Okay, a tiebreaker. Standard practice. And once they had the final list of included studies, what specific information did they pull out of them? What data points did they extract?
They designed a structured data extraction table, which they refined with a pilot extraction phase first. The main categories of data they extracted were quite comprehensive.
Like what?
They noted the basic study details like the title, authors, year of publication, the country where the research was conducted, which, as we'll see, gives us a sense of the geographic spread of this research and the study design.
Okay, the basics.
They extracted characteristics of the patient sample, including the total number of participants and their age range. This is how we know the review ultimately included data from a total of 1,042 patients across the included studies.
Over 1,000 kids and teens.
Ranging in age from 3 to 18, with a breakdown of approximately 41% male and 59% female.
Okay. What about the specifics of the bleaching interventions themselves? That's crucial for clinical practice.
Absolutely. They extracted detailed information on the bleaching technique used in each study, whether it was in-office, at home, using trays, over-the-counter strips, or even combined approaches.
Right, the how.
They also noted the specific type of bleaching agent used, like hydrogen peroxide, carbamide peroxide, sodium perborate, or others, the concentration of the agent, and any specific application details, such as the type of applicator tip used or whether a light source was employed for activation.
So the real nitty-gritty details.
Yes. Crucially, they extracted information about the specific protocol, followed the number of sessions, the duration of application per session, and the total treatment time.
Okay. And finally, the outcomes. What data did they extract regarding what actually happened to the patients? Did it work? Was it safe? Were they happy?
Exactly. This included the clinical outcomes and the patient's experience. They extracted data on how patient satisfaction was measured and what the results were, how color change was assessed, objective or subjective methods, the specific reasons the patients underwent bleaching in that study, revisiting that list we discussed earlier.
Right.
Safety outcomes like the incidence and severity of bleaching sensitivity and gingival irritation, any other side effects that were reported, the length of the follow-up period after treatment, and whether or not any additional treatments were deemed necessary after the bleaching was completed.
So pretty much everything a clinician would want to know.
By extracting all this, they built a detailed picture of what the existing literature has reported on tooth bleaching in this age group.
Okay, that gives us a really solid understanding of how they conducted this comprehensive review. Now let's get to the most important part for us as clinicians. What did all this systematic mapping actually reveal? What were the findings from the 40 studies they included? So after that extensive search and screening process, the reviewers ended up with a final pool of 40 studies that met their inclusion criteria. First, where were these studies coming from globally? Any particular hotspots?
Yeah, the review provides a breakdown of the origin countries, giving us a sense of where this research is most active. The majority of the studies originated from Brazil, contributing 12 articles.
Brazil, okay.
Following Brazil were the United States with 9 articles and India with 7.
U.S. and India also significant.
Right. The remaining studies came from the UK, Turkey, Australia, Germany, Ireland, and Iran. It shows this is a relevant clinical topic and area of research across various parts of the world.
Okay, a good international mix.
Sure.
And what about the types of studies they found? What kind of evidence level are we looking at in this pool of 40, mostly case reports. Trials.
The mix of study designs is important context for interpreting the findings. The largest group consisted of case reports, or case report series, totaling 21 studies.
Okay, so over half are case reports.
Yes. These offer valuable individual insights and document clinical experiences, but represent a lower level of evidence compared to controlled trials,
Right. Anecdotal in a way.
Somewhat. They also included 15 clinical studies, which likely included some form of intervention and follow-up on a group of patients. Finally, there were 4 prospective studies.
Okay. Following patients forward.
Yes, but the reviewers specifically note that 2 of these prospective studies were observational in nature, meaning they used questionnaires to assess patient satisfaction and psychosocial effects without directly performing a bleaching intervention themselves.
Okay, so not all were intervention studies.
Correct. So while we have some clinical trials, a significant portion of the evidence mapped here comes from observational data and individual case reports. You need to keep that in mind.
Good point. Okay, let's circle back to the reasons for bleaching. But now looking at the frequency within these included studies, what popped up most often?
Right. As we touched on earlier, general tooth discoloration was the most common reason cited, appearing in 20 articles. And importantly, in 8 of those 20, the discoloration was attributed to previous dental trauma.
Trauma again.
Confirming its prevalence as a cause for concern. Dental fluorosis was the second most frequent reason, addressed in 12 articles.
Fluorosis, right.
The less common indications, appearing in just 1 or 2 articles, included hypomineralization, hypoplasia, MIH, amelogenesis imperfecta, and unclassified brown staining. This confirms that clinicians are considering bleaching for a relatively wide spectrum of discolorations in this age group.
Okay. Now, the core of the treatment itself, the techniques and agents used in these studies, what did they find?
The studies covered both vital and non-vital bleaching approaches. Vital bleaching was performed in 30 studies.
The majority of them.
Utilizing various techniques such as in-office procedures, at-home treatment with custom trays, the use of over-the-counter strips combined in-office and at-home methods, and even microabrasion combined with in-office bleaching.
So pretty much all the ways we do it.
Yeah. 8 studies focused specifically on non-vital bleaching, employing techniques like the walking bleach method, inside-outside bleaching, external bleaching, internal bleaching, and combinations of walking bleach with in-office procedures or inside-outside with microabrasion.
Okay. And the agents.
Yeah.
What were the workhorses and what else showed up? Hydrogen peroxide,
Well,
carbamide peroxide.
Yep, the primary agents were hydrogen peroxide, or HP, which was used across a wide range of concentrations from 6% up to a high of 36%.
6 to 36% HP. Okay.
Carbamide peroxide, or CP, was also frequently used in concentrations from 10% up to 44%.
10 to 44 CP. Wow. 44% is pretty high.
It is. Beyond these common agents, the studies also utilized sodium proborate, or SP, particularly for non-vital cases, 5% sodium hypochlorite, or AOCl, and a specific formulation known as McInnes solution.
Okay, sodium perborate, sodium hypochlorite, McInnes solution. Interesting variety. Now, this is a crucial point for clinicians listening. Minimum ages reported in these studies for using specific techniques. What did they find? Can you really bleach a 4-year-old's teeth?
This is very practical information drawn directly from the included literature, and yeah, the ages were surprisingly low in some reports. For the in-office technique, the minimum age reported was 6 years old.
6 for in-office.
This was in studies where 35% HP gel was used, typically for treating fluorosis. For the at-home technique, the lowest age noted was 4 years old.
4 years old.
In a case report describing a patient using 10% CP for 1 hour per day.
Wow, okay. And strips.
Over-the-counter strips saw their minimum age reported as 11 years old, where participants used 6.5% HP strips.
11 for strips.
And surprisingly, for non-vital bleaching using the inside-outside technique, a case report included a 3-year-old child who was treated with 35% HP.
3 years old for non-vital. Okay, these are specific examples from the studies, showing that practitioners have used these techniques even in very young children, though maybe not standard practice.
Exactly. It shows what's been reported in the literature they captured.
Those ages are quite low.
Yeah.
What about the concentrations used across the different techniques? Did they vary much?
Yeah, they did. For in-office vital bleaching, they reported a range of HP concentrations, from that lower 6% used in some Brazilian studies, which the review links to a trend seen in Europe.
Okay, 6% HP in office.
Up through 20%, combined with TIONTM in one study, 25%, 30%, 35%, and even 36%.
So a big range for in-office HP?
Yes. One study used a very high 44% CP in office.
Right, that 44%.
For at-home and over-the-counter techniques, as you might expect, the concentrations were generally lower, with HP ranging from 6.5% to 14%.
6.5 to 14 HP at home OTC.
And CP from 10% to 16%.
10 to 16 CP. Okay, generally lower for home use. Makes sense.
Sodium perborate was predominantly used for non-vital bleaching in 6 out of the 8 relevant studies. 2 studies used 35% HP for non-vital bleaching, and 1 used 10% CP.
Okay, mostly SP for non-vital, but some HP and CP too. And the application protocols.
Yeah.
How much variation was there in how these agents were actually applied? Like number of sessions, time per session?
There was significant variation across the studies, highlighting a lack of standardization in the literature.
Not surprising, maybe.
No. For in-office vital bleaching, protocols ranged from just 1 to 3 applications within a single session, with varying application times per application. For instance, 3 by 15 minutes with 35% HP, or a single 60-minute session with 30% HP.
Okay, quite different approaches.
Home treatments and OTC strips saw treatment durations varying massively, from just 14 days all the way up to 4 months in some cases.
2 weeks to 4 months. Huge range.
Yeah. Walking bleach techniques for non-vital teeth were typically used for 1 to 4 weeks, while inside-outside techniques range from 4 to 6 days or sessions.
Okay. You mentioned some less common agents earlier, like NaOCl and McInnes solution. What did the review reveal about their use? Were they effective?
The review noted a study that used 5% sodium hypochlorite for dental fluorosis, concluding it was only effective for light stains, not moderate to severe discoloration.
So limited use for NaOCl.
Yeah. They explained its mechanism is related to degrading organic components. Another study used hydrogen peroxide combined with a specific product called GC-TION-TM for severe hypomineralization stains and reported aesthetic improvement.
Okay. And McInnes.
The McInnes solution, a combination of hydrochloric acid, hydrogen peroxide, and diethyl ether, was reported as providing satisfactory results for fluorosis in one study.
Interesting mix.
With the mechanism involving HCl etching, HP bleaching, and ether acting as a solvent. It's interesting to see these alternative approaches appearing in the literature for specific types of stains, even if not mainstream.
Definitely. Were there any particularly interesting details about the in-office vital techniques beyond just the agent and concentration, like barriers or applicators?
Yes, the review pulled out some specifics that offer practical insights. They noted variations in the number and duration of applications within a session, like protocols using 3 by 15 minutes of 35% HP activated by LED, or 3 by 20 minutes of microabrasion followed by 44% CP, or even a single 60-minute application of 30% HP.
Right, the protocol variations.
A study investigated the use of a gingival barrier with 6% HP in office and found no statistically significant difference in the outcome whether a barrier was used or not.
Okay. With 6% HP, anyway.
Another study looked at different applicator tips with 6% HP and found that using an applicator tip without a brush might lead to better color change after 3 weeks.
Interesting.
But conversely, using the brush tip seemed to result in less reported sensitivity.
Trade-off, perhaps. Better whitening versus less sensitivity.
Potentially. These details highlight areas where technique variation is being explored in the literature.
And for the over-the-counter strips, was the protocol generally consistent across the studies using them?
Yes, for OTC strips, the protocol was remarkably consistent in the included studies, typically 30 minutes applied twice a day.
Okay, 30 minutes twice daily. Pretty standard.
The main variation was simply the total duration of use, which ranged from 14 days up to 28 days across different products or studies.
Got it. At-home tray bleaching protocols can vary wildly in how long patients wear the trays. Overnight. An hour. What did the review find there?
That variation was evident in the reviewed literature as well. Protocols included wearing trays overnight or for specific durations during the day, like 1 hour, 3 hours, or 4 hours per day.
All over the map.
Yeah. The total duration of the at-home treatment also varied significantly, from just a couple of weeks, 14 days, up to a substantial 4 months in one case.
4 months again. Wow.
This really underscores the lack of a single standardized at-home protocol, even within the existing studies.
Absolutely. And finally, just summing up the techniques and agents used for non-vital bleaching in these young patients again.
Sure. For the 8 studies focused on non-vital bleaching, the majority, 5 out of the 7 studies that mention the agent, use sodium perborate, primarily with the walking bleach technique.
SP mostly.
2 studies used hydrogen peroxide, sometimes combined with walking bleach or in-office approaches, and 1 study used 10% carbamide peroxide with the inside-outside technique.
Okay.
This gives us a picture that while HP was used, SP and lower concentration CP were also common, likely reflecting an emphasis on minimizing risk in non-vital cases in this age group, a point we'll return to when we discuss safety.
Right, the resorption risk. Okay, that's an incredible amount of detail on how these procedures were performed in the studies. Now, let's get to the outcomes that really matter. Safety, particularly sensitivity and irritation, and the patient's prospective satisfaction. Okay, let's move on to what happened after the bleaching was done. We'll start with patient satisfaction, which, as we discussed, has significant psychosocial implications. What did the review reveal about how satisfied young patients were with their bleaching results? Were they happy?
This is a critical area, but the review highlights a significant limitation in the current literature. A large percentage of the included studies, 44%, simply did not report on patient satisfaction at all.
Nearly half didn't even mention it. Wow.
Yeah. This means we have an incomplete picture of the patient experience across the mapped literature.
That's a big gap, especially considering why we might offer this treatment in the first place.
Yeah.
The psychosocial angle.
It really is. However, among the studies that did report on satisfaction, the findings were overwhelmingly positive.
Oh, good.
The vast majority reported that patients were satisfied with the outcomes, noting clear improvements in their dental appearance and, importantly, their overall quality of life.
Okay.
This strongly supports the potential psychosocial benefits we discussed earlier.
Were there any instances where patients were not satisfied or where it just didn't work well enough?
Yes, the review specifically points out 2 case reports where the patient was not satisfied after bleaching and required further treatment. One case involved a patient with a melanogenesis imperfecta.
Okay, a complex case.
Who was treated with at-home CP and microabrasion, but ultimately needed resin composite veneers to achieve a satisfactory aesthetic. The other was a patient with fluorosis treated with in-office HP and microabrasion who still needed more microabrasion afterward.
Right, so managing expectations is key, especially with underlying conditions.
Exactly. These cases underscore that for complex structural discoloration like severe hypoplasia or fluorosis, bleaching might be just one part of a larger treatment plan.
You mentioned earlier that some prospective studies specifically looked at psychosocial effects. What were their findings? Did bleaching actually help kids feel better?
2 prospective studies provided valuable insights into this. One observed a positive impact on patients' emotions and their school experience. Patients reported feeling less irritable, nervous, and upset about their teeth after treatment.
Really? Less irritable and nervous?
Yeah. It also reportedly reduced instances of missed school days, avoiding smiling, speaking problems, and feeling left out socially.
Wow, that's significant.
The other prospective study used questionnaires to evaluate satisfaction more broadly and found very positive results. 89% reported improved appearance, 81% felt improved confidence, 59% felt very confident.
Very confident.
And 85% said they would recommend the treatment to a friend.
Those are strong numbers.
These findings strongly reinforce the real-world impact of successful bleaching on young patients' well-being.
That's powerful evidence for the why. Now let's confront the big concern for clinicians. Bleaching sensitivity. The ouch factor. What did this review find about the incidence and nature of sensitivity in children and adolescents?
Bleaching sensitivity was reported in a significant number of studies, 11 out of the 29 that performed vital bleaching.
Okay, so it definitely happens. Was it bad?
The good news is that in the vast majority of these reports, the sensitivity was described as being mild and transient.
Mild and transient. Okay, that's key.
Meaning it resolved on its own, typically after treatment stopped or between applications.
We often worry that younger patients are more susceptible to sensitivity because of their larger pulp chambers and thinner dentin. Did the review address this theoretical risk?
Yes, the source acknowledges this common concern, the theoretical risk posed by the larger pulp volume and thinner dentin in young permanent teeth. However, it also presents a counterbalance.
Oh.
Suggesting that potential mitigating factors in this age group, such as having fewer enamel cracks, less gingival recession, and possibly better pulp recovery capabilities, might reduce the actual perception or severity of sensitivity compared to adult patients with similar procedures.
Interesting. So maybe not as bad in practice as theory might suggest.
Possibly, but the data needs to be robust to confirm that.
How is sensitivity measured in these studies? Was there a standardized way to assess it in children? Or just asking, does it hurt?
Unfortunately, this was a major limitation noted by the reviewers. There was a significant lack of standardization in how sensitivity was assessed.
Not good.
11 studies relied solely on the patient's self-report without using any validated scale, which makes it difficult to compare findings across studies or quantify the level of discomfort accurately.
Right. Mild to one kid might be different for another.
Exactly. Some studies combined self-report with pulp vitality tests. Only 3 studies used validated pain scales. 2 used a numeric rating scale, NRS, and 1 used a visual analog scale, VAS.
Only 3 used proper scales.
Yeah. The reviewers strongly emphasized the critical need for using validated pain scales specifically designed for children and adolescents, such as the NRS for those over 8 years old, or pictorial VAS scales, which can be used even with children as young as 3, to obtain more accurate, objective, and comparable data on sensitivity in future research.
Absolutely crucial for future studies. Okay, was sensitivity linked to particular agents or concentrations in the studies that reported it? Like, does stronger stuff cause more sensitivity?
Well, bleaching sensitivity was reported across the board, meaning it occurred with all the hydrogen peroxide concentrations used in office, from 6% up to 36%, and with the 44% carbamide peroxide used in one study.
So it can happen with anything.
Pretty much. For at-home and over-the-counter techniques, sensitivity was also reported across all HP concentrations, from 6.5% to 14%, and CP concentrations, 10% and 15%.
Okay.
However, a key observation was that a lower rate of bleaching sensitivity was specifically noted when lower concentrations were used in the at-home technique, namely with 6.5% HP or 10% CP.
Ah, okay. So lower concentrations might mean less sensitivity at home. That makes sense.
It does seem to align with clinical intuition. The study using McKenna's solution for fluorosis also reported mild and transient sensitivity.
This is a really important clinical takeaway. Could sensitivity be severe enough to make patients actually stop treatment? Did anyone drop out?
Yes, and this is a critical point highlighted by the review. While sensitivity was generally mild, 2 studies explicitly reported patients discontinuing their treatment prematurely because of bleaching sensitivity.
Okay, so it can be bad enough to stop.
Yes. Both of these instances occurred with home-use products, one with over-the-counter strips using 9.5% and 14% HP, and the other with at-home bleaching using 10% CP.
Interesting. Both home use.
This tells us that while often manageable, sensitivity is a real factor that can impact patient compliance and treatment success, particularly with home-supervised techniques. One prospective study also reporting that 63% of pediatric patients experienced some form of BS, though the specific technique they were evaluating wasn't detailed in the abstract.
53%. That sounds high, even if mild. Okay, what about other side effects like gingival irritation, sore gums?
And the review noted a significant reporting gap here. A large number of studies, 18 out of the 38 intervention studies, provided no information at all on whether gingival irritation or any other side effects occurred.
18 didn't mention it at all. Isn't that great?
No. On the positive side, 9 studies explicitly reported that no gingival irritation or other side effects were observed.
Okay, 9 said none. When irritation was reported, where did it seem to happen more often? In office. At home.
For the in-office technique, gingival irritation was reported in only one study, where it occurred with 6% HP in both the group that used a gingival barrier and the group that didn't.
Only one study for in-office.
However, gingival irritation was much more commonly reported in studies using at-home techniques and over-the-counter strips.
Uh-huh. More common at home. Why?
It appeared across all the reported HP concentrations in these categories, with the 6.5% HP showing the lowest percentage, and with 10% CP. The review logically attributes this higher incidence with home-use products to direct contact between the bleaching agent and the gingival tissues.
Makes sense. Leaky trays or strips.
Likely due to imperfect adaptation of trays or strips leading to extravasation. This contrasts sharply with the in-office setting, where the routine use of gingival barriers and direct professional supervision significantly reduces the likelihood of agent contact with soft tissues. This difference might also explain why treatment dropout due to side effects was reported in some at-home OTC studies, but not in any of the in-office studies included in the review.
Okay, that's a really practical point. Supervision and barriers matter for irritation. Let's talk about non-vital bleaching safety. One major concern in young permanent teeth is the risk of cervical resorption, right? Did the review find any reported cases of this?
This is actually a very positive and reassuring finding from the review. None of the 8 studies that reported on non-vital bleaching procedures in children and adolescents reported any cases of cervical resorption.
None at all. That's great news.
It is. This is a well-known, serious potential complication associated with non-vital bleaching, often linked to the use of high concentrations of hydrogen peroxide, especially in teeth with open apices or thin radicular dentin.
Right, particularly with heat or high concentrations.
Exactly. The absence of reported cases in these studies is likely due to the types of agents and protocols favored in the reviewed literature, which, as the review notes, aligns with recommendations to use sodium perborate or lower concentrations of HP or CP for non-vital bleaching in young patients to minimize this risk.
So they are likely using safer agents like SP.
Yes, the majority of the non-vital studies, 5 out of the 7 that specified the agent, used SP, and 1 used 10% CP. Even the single study that used 35% HP for non-vital did not report any side effects, including resorption over a 4-year follow-up period.
Okay, that's really encouraging for non-vital cases. Finally, let's look at the primary objective color change. Did it work? How effective were these procedures overall in whitening teeth?
Here again, the review highlights a significant limitation in the available literature. A large number of the intervention studies, 21 out of the 38, did not analyze or report on color change at all.
21 didn't report color change. How can you do a bleaching study and not report color change?
It's surprising. This makes it challenging to draw sweeping conclusions about efficacy across the entire body of evidence.
Okay, but for the studies that did measure color change, how did they do it and what did they find? Did the teeth get whiter?
Yes. Studies used both objective and subjective methods. Objective assessments, which are preferred for their consistency and lack of operator bias, included using devices like colorimeters and spectrophotometers.
It's fancy machines.
Or analyzing digital photographs using calibrated software. The review mentions specific objective formulas used, such as BE, which measures overall color difference, AE, yellow-blue change, A, lightness change, and VD, which measures whiteness index and is specifically recommended by the reviewers for evaluating bleaching effectiveness.
Okay, EEA, good objective measures. And subjective.
Subjective assessments relied on visual comparisons using standard shade guides like the VITA scale or other visual assessment scales.
Right, just looking at the shade tab.
The key finding, across the studies that did report color change using either method, is that a statistically significant color change was consistently observed.
Okay, so it works.
This improvement in color happened regardless of the specific type or concentration of the bleaching agent used or the technique employed.
So it seems the procedures are effective at changing color when applied, generally speaking.
Yes, they appear effective at inducing noticeable color change. However, there was some nuance. 2 studies specifically reported that using higher concentrations led to a greater magnitude of color change.
Ah, okay. Stronger means whiter sometimes.
For instance, one study found that 9.5% HP-OTC strips resulted in more color reduction than 6.5% HP-OTC strips, and another found that 10% CP at home was more effective than 6.5% HP-OTC strips, particularly in the mandibular arch. But broadly speaking, the studies indicated that various agents and concentrations could achieve significant whitening.
Okay. That gives us a really comprehensive look at the findings regarding efficacy, safety, and patient experience. Now let's dig a little deeper into how different approaches compared and what happened when bleaching alone wasn't enough. So with all these different techniques, agents, and concentrations being used across the 40 studies, did the review find many direct comparisons to help us figure out which approach might be superior? Like, is in-office better than at home for kids?
This is another area the review points to as a major gap in the literature. Out of the 38 studies that involved an intervention, only 8 actually made direct comparisons between different techniques, agents, or concentrations.
Only 8 comparison studies. Out of 38, that's not many.
No, it's a relatively small number for drawing strong comparative conclusions.
Okay. And what did those 8 comparison studies find? Any clear winners?
The results from these limited comparisons were somewhat mixed, particularly regarding concentrations, when comparing the same agent and technique at different concentrations.
Like 10%, 15% CP?
Exactly. One study found that a higher concentration, 9.5% HP-OTC, led to greater color reduction than a lower one, 6.5% HP-OTC. Okay, higher was better there.
Right.
However, other studies comparing different concentrations, such as 6.5% versus 10% HP-OTC, or 25% versus 36% HP in office, found no statistically significant difference in color change between the 2 concentrations.
Huh. So sometimes higher concentration didn't make a difference in whitening.
Apparently not, according to those studies. This is a clinically important observation, It suggests that in some situations, using significantly higher concentrations might not necessarily provide a clinically meaningful improvement in the amount of whitening compared to lower concentration.
Which might be good news if you're worried about side effects.
Precisely. It could have implications for managing side effects, like sensitivity. Maybe lower is enough sometimes.
What about comparisons specifically for treating fluorosis stains? That's a common indication for bleaching in younger patients and can be tricky.
2 studies focused on comparing approaches for fluorosis. One compared different in-office techniques. 35% HP with LED light, 44% CP combined with enamel microabrasion, and 5% sodium hypochlorite.
Okay, comparing 3 ways.
It concluded that both the HPLED and CP microabrasion approaches were equally effective for removing fluorosis stains.
Okay, HP and CP microabrasion worked.
While the sodium hypochlorite was only effective for light stains.
Right, we heard that before about NaOCl.
Yeah. This suggests that for moderate to severe fluorosis, you likely need a more aggressive or combined approach. Another study compared a single in-office session with 30% HP alone versus a combination approach using in-office 30% HP, followed by at-home 15% CP for fluorosis.
Single session versus combo.
They found that the single in-office session wasn't effective for moderate or severe stains, but the combination technique successfully removed both moderate and mild stains.
So combo therapy wins for tougher fluorosis cases.
That's what this study suggests. It reinforces the idea that for challenging cases like moderate to severe fluorosis, a single modality or a lower concentration might not be sufficient, and combined techniques could be necessary.
And how did different techniques compare overall, like over-the-counter strips versus at-home trays with custom trays?
Generally, the studies comparing OTC HP strips and at-home CP bleaching using custom trays found that both approaches were effective at producing color change, often with no statistically significant differences in overall efficacy between them.
Okay, so strips versus trays often came out similar in whitening power.
Yeah. For instance, comparisons between 10% HP OTC strips and 10% CP at home, or 14% HP OTC strips and 10% CP at home, showed similar results in terms of color change. One study did find 10% CP at home to be more effective than 6.5% HP OTC in the mandibular arch, but not in the maxilla.
A slight difference there.
The review posits that since the efficacy seems relatively comparable across these home use techniques in many cases, the choice between them might depend more on factors like patient preference, comfort, cost, and clinical practicality rather than a substantial difference in whitening power.
Makes sense. Compliance and ease of use might be bigger factors than the chemistry sometimes. Okay. We saw earlier that in some cases, bleaching wasn't the end of the treatment. How often was additional treatment needed, and what kind? Did they need fillings or veneers afterwards sometimes?
Of the 38 intervention studies, 17 reported that no additional interventions were needed after the bleaching. So in many cases, bleaching was enough.
Okay, about half the time maybe.
But additional treatment was indeed required in a significant number of cases, particularly those with more complex underlying conditions. 11 studies reported needing microabrasion after the bleaching procedure.
Microabrasion. Okay, for what kinds of things?
This was commonly done for residual fluorosis stains, but also for MIH and other types of discoloration that weren't fully resolved by bleaching alone. One study specifically suggested that for moderate fluorosis, combining bleaching with enamel microabrasion might lead to better outcomes.
Right, the combo approach again.
Furthermore, 7 studies reported needing resin composite restorations as an additional treatment.
Composite fillings or veneers?
Yes. These were typically for patients with more severe underlying issues, like hypomineralization with significant dark stains, hypoplasia, amelogenesis imperfecta, or extensive discoloration following traumatic injury.
Okay, so for structural defects or really deep stains, bleaching might just be step 1.
Exactly. It highlights that while bleaching is powerful for structural tooth defects or very severe stains, it might serve as an important preparatory step for definitive restorative treatment.
What about follow-up time? How long did the studies track these young patients after treatment? Did the whitening last?
Well, 6 studies didn't report any information on their follow-up duration, which is a limitation.
Another reporting gap.
Yeah. For those that did, the follow-up periods varied widely, from a minimum of just 2 weeks up to an impressive 7 years in one case report.
7 years? Wow.
That followed a patient treated with 10% CP at home for a brown stain and reported the stability of the result over that entire period.
That's great to hear stability over 7 years.
It's just one case, but it's a valuable data point suggesting long-term stability is possible. The majority of studies followed patients for at least 1 month, which often coincided with the timing of their final color assessment. Only 7 studies had follow-up periods shorter than 1 month.
Okay. So mostly short-term follow-up, but one long-term success story. This review has really mapped out a detailed picture of the available evidence. Let's bring it all together now and discuss what it means for us, the dentists, in practice. What's the bottom line? So, based on synthesizing all the clinical studies and case reports mapped in this scoping review, how can we summarize the current state of evidence regarding tooth bleaching in children and adolescents? What's the big picture?
The review's discussion provides a clear synthesis. It concludes that, based on the available literature, tooth bleaching appears to be an effective treatment for achieving noticeable and statistically significant changes in tooth color in children and adolescents.
Okay, effective. Check.
Crucially, it also appears to be generally safe in this population, with the reported side effects, primarily bleaching sensitivity and gingival irritation, typically described as mild and transient.
Generally safe, mild, transient side effects. Check.
And from the patient's perspective, the studies that reported on satisfaction indicated that most patients were indeed happy with the outcomes.
Patient satisfied. Check. That sounds pretty positive overall.
And it does sound reassuring.
But does the review identify a single best way to bleach younger teeth? Is there a consensus on the optimal technique, agent, or concentration? Did they say use this, not that?
No, and this is a major takeaway from the review. The authors explicitly state that based on the current literature, there is no unanimous consensus on the single best technique, agent, or concentration to use for bleaching in children and adolescents.
No magic bullet.
Okay. While in-office and at-home OTC techniques were represented in a similar number of studies, suggesting they are both widely used, the review couldn't point to one being definitively superior across the board.
But they did highlight some potential advantages of each approach,
Okay.
right? Pros and cons.
Yes, they discuss practical advantages from the clinician's point of view. For in-office bleaching, advantages include not relying on patient cooperation,
Huge for some kids.
which can be key in younger or less compliant patients. It's also generally easier for the clinician to manage, requires a shorter total treatment time compared to weeks or months of home use, and allows for direct, ongoing professional monitoring of the process and any immediate side effects.
Right. Control and speed for in-office.
Exactly.
And for at-home bleaching. What are the upsides there?
The advantages for at-home treatment include the comfort and convenience of being able to perform the treatment at home, often with valuable supervision from parents or guardians. It also requires less chair time for the patient, which can be a factor for scheduling and cost.
Comfort, convenience, less chair time.
And the review notes that recent advances in digital dentistry, like using intraoral scanners to create more accurately fitting custom trays, make at-home bleaching a more precise and comfortable option than perhaps it was previously.
Good point. Better trays might mean less irritation, too. Okay, what about that debate over concentration? We saw mixed results on whether higher concentrations were significantly more effective. What did the review conclude?
Precisely. The review points out that the findings on whether higher concentrations of bleaching agents result in significantly better color change are not unanimous across the literature.
Not unanimous. Key phrase.
While some studies showed a benefit to higher concentrations, others found similar outcomes with both low and high concentrations. This has important clinical implications. It suggests that using the highest available concentration might not always be necessary to achieve a satisfactory result.
Right.
And potentially opting for lower concentrations, particularly in home use products, might be a reasonable approach when balancing efficacy with the potential for increased side effects like sensitivity, as seen in some studies.
Okay, so don't just automatically reach for the strongest stuff. Consider if a lower concentration might work with fewer side effects.
That seems to be a reasonable interpretation of the mixed findings.
And for managing fluorosis, what's the key takeaway strategy from the review? What works best?
For fluorosis, the key takeaway reinforced by the review is that the choice of agent and technique should be guided by the severity of the stain. For moderate to severe fluorosis, the literature suggests that achieving satisfactory results often requires more than a single, simple approach.
Right, need the bigger guns or combination therapy.
Combined techniques, such as using both in-office and at-home bleaching sequentially, or combining bleaching with enamel microabrasion, appear to be more effective for these challenging cases than bleaching alone or using lower concentrations.
Got it. Tailor the approach to the severity, especially for fluorosis. Patient satisfaction sounded overwhelmingly positive in the studies that reported it, but that reporting gap is a limitation, right?
Absolutely. The reported positive impact on self-esteem, confidence, and quality of life is a powerful argument for offering this treatment when indicated. But the fact that nearly half the studies didn't report on this means the full picture of the patient experience across the literature is incomplete.
Yeah.
It underscores that future research must include patient-reported outcomes using validated measures. We need to hear the patient's voice more consistently.
And how should we think about managing those expected side effects like sensitivity and irritation based on these findings? What's the practical advice?
The review reinforces that while sensitivity and irritation are common, they are typically mild and transient. Manage expectations. A key finding for managing irritation is recognizing that it appears more frequently with at-home and OTC products.
Right, the leaky trays issue.
Likely due to issues with tray fit and agent extravasation onto the gingiva. This suggests that in-office treatment, with the use of gingival barriers and direct professional supervision, might be better for minimizing soft tissue irritation.
So if irritation is a big concern, maybe lean towards in-office.
It might mitigate that specific risk better. It also explains why treatment dropout due to sensitivity was reported in some home use studies, but not in the supervised in-office treatments within this review.
Good point.
Clinicians should thoroughly explain the potential for these mild side effects and provide strategies for managing them, especially with home use products, desensitizing toothpastes, adjusting wear time, etc.
Right, proactive management. And that reassuring finding about non-vital bleaching safety, no cervical resorption reported, that seems like a big positive.
That's a significant positive finding, yes. The absence of reported cervical resorption in these studies, despite it being a known risk with non-vital bleaching, particularly in young teeth, is encouraging.
Definitely reduces one major anxiety about non-vital.
The review attributes this favorably to the common use of sodium perborate or lower concentrations of carbamide peroxide in the reviewed studies, which aligns with current best practice recommendations aimed at minimizing this specific risk in immature or developing teeth. So stick with SP or lower CP for non-vital in kids seems supported.
Okay. What were the major limitations of the existing literature that the reviewers highlighted? What weaknesses make drawing definitive conclusions difficult?
They identified several crucial shortcomings in the included studies. These include a significant lack of standardization in how color change was assessed,
The measurement problem.
emphasizing the need for objective methods in the future. Many case reports, which formed a large part of the sample, didn't adequately report on side effects.
Right, the reporting gaps.
Most clinical trials used parallel designs rather than the more controlled split-mouth design, where one side of the mouth acts as a control for the other.
Less robust study design.
And perhaps most critically, for assessing safety, there was a widespread absence of validated pain scales specifically designed for children and adolescents.
The sensitivity measurement issue again.
Meaning most studies relied on less precise self-report for sensitivity assessment.
So while the evidence appears promising based on this synthesis, there are definite areas where the foundation of evidence is still weak or inconsistent. Lots of seems and appears.
Precisely. The synthesized conclusion is that bleaching seems safe and effective, promoting good color change with mild side effects, and patients seem happy. But the limitations mean we don't yet have a robust, high-level body of evidence to provide strict clinical guidelines or declare one approach definitively better than others in all scenarios.
This brings us to the final part of our deep dive. What research is still needed based on this review, and what are the key takeaways for you, the dentist, in your practice today? What can we do now? So, given the limitations identified and the overall landscape mapped by this review, what are the clear directions for future research that the authors point towards? What studies do we need next?
The reviewers are quite specific about the kinds of studies needed to move this field forward and provide more definitive guidance for clinicians. They call for future clinical studies that directly compare in-office and at-home bleaching techniques, specifically in children and adolescents.
Head-to-head comparisons.
As this was largely missing from the literature they found. They also highlight a complete void in the research regarding safe protocols or intervals for repeating bleaching treatment in this young population.
How often can you re-bleach a kid's teeth? Nobody studied that.
Apparently not. This aspect wasn't addressed in any of the included articles, representing a significant gap for long-term treatment planning.
Okay, big question mark there. What else?
Beyond comparative effectiveness, they emphasize the crucial need for standardization in future studies. This includes standardizing how color change is assessed, moving towards objective methods whenever possible.
Right, use the machines.
And perhaps most importantly, for evaluating safety, standardizing the assessment of sensitivity, using validated pain scales specifically appropriate for children and adolescents, rather than relying on simple self-report.
Use the right pain scales for kids. Makes sense.
Finally, they suggest that future systematic reviews that also assess the quality of the included primary studies are needed to provide a higher level of evidence for clinical recommendations. This scoping review mapped it out. Now we need systematic reviews to judge the quality and maybe do meta-analyses if possible.
Okay, so this scoping review gives us confidence in the general direction that it seems to work and seems safe, but it leaves plenty of room for more rigorous research to refine our approaches.
That's exactly right. The synthesized conclusion from the review is that tooth bleaching appears to be a safe and effective treatment for children and adolescents, resulting in satisfactory color change with side effects that are generally mild and transient. However, the review emphasizes the lack of unanimous consensus on the absolute best technique, agent, or concentration, which underscores the need for more targeted, higher-quality research to build on this foundation.
So what does all of this synthesized information mean for you, the dentist, in your practice right now? We've seen the evidence suggesting efficacy, the apparent safety profile, the significant positive impact on patient well-being, but also the clear limitations in the existing research. How do we integrate this knowledge into our daily clinical decisions today? What's the practical takeaway?
It means that based on this comprehensive synthesis of the available literature, you can feel more confident in offering tooth bleaching as a viable and beneficial treatment option for eligible younger patients when clinically indicated.
Okay, more confident to offer it.
The widespread concerns about severe, irreversible side effects don't seem to be broadly supported by the included studies, although you should certainly anticipate and discuss the possibility of mild, transient sensitivity and irritation. Manage expectations.
Right. Discuss the mild stuff up front.
However, because the evidence doesn't yet provide a unanimous consensus on the single optimal approach for every situation, your informed clinical judgment remains paramount.
Still comes down to the clinician's call for the specific patient.
Absolutely. You need to consider the specific clinical presentation. What is the underlying reason for the discoloration? What is the patient's age, developmental stage, and expected cooperation level? How severe is the stain? This review provides you with a stronger, evidence-informed base to draw upon for those case-by-case decisions, helping you move beyond uncertainty while we await further definitive research to refine specific protocols.
It provides a foundation of evidence that supports considering the treatment, even if it doesn't give us a strict one-size-fits-all guideline. It moves the needle from, should I even think about this? To, okay, how should I think about this for this patient?
Exactly. It equips you with synthesized knowledge to have more confident discussions with parents and patients and to make more evidence-informed decisions within the acknowledged limitations of the current literature.
Okay, here's a thought to leave you with, building on everything we've explored today. Given the significant psychosocial benefits highlighted in this review, the improvements in self-esteem, confidence, and overall quality of life, and the apparent safety profile, how might a more proactive, evidence-based approach to discussing and offering tooth bleaching to eligible young patients positively impact our lives, not just dentally, but emotionally?
That's a powerful question.
What specific steps can you take now, armed with the knowledge from this deep dive, to make more informed decisions, manage expectations regarding potential side effects like sensitivity, and select techniques you feel are best suited for each individual younger patient you see, even as we look forward to that future research that will continue to refine our practice?
Consider the opportunity to not just brighten a smile, but to genuinely enhance a young person's well-being during a critical time of development. It's more than just teeth, right?
Absolutely. That's a wrap on this deep dive into the scoping review on tooth bleaching in children and adolescents. We hope this exploration has provided you with valuable insights for your clinical practice.
Thank you for joining us. Until next time.